Hi, my name is Estie Pt2. I'm a genetic counselor at Montefiore Medical Center and with the Program for Jewish Genetic Health of Yeshiva University. In our last lecture, we reviewed some basic concepts in genetics, which will hopefully give you a better understanding of the more complex issues to come. In this lecture, we'll review the differences between different types of genetics professionals and also discuss some of the ethical, legal, and social issues that come up related to genetics. So let's start with who's who in genetics. The three players in genetics are the medical geneticist, the people in the lab, and the genetic counselor. Medical geneticists are medical doctors. They usually have trained as OBGYNs, or internists, or pediatricians, and then they completed a specialty training in medical genetics. Reproductive medical geneticists deal with pregnant women who are at risk for their fetus to have a genetic disease, and they order appropriate genetic testing. I'll go into more detail about that in a later slide. Adult medicine and pediatric geneticists evaluate individuals who are suspected to have genetic diseases and offer appropriate testing. When a genetic test is ordered, the patient's sample, which is often blood, is sent to a lab. Because it's a clinical lab and not a research lab, the lab must meet certain standards to do genetic testing. Labs are run and overseen by certified specialists who have to review each and every result. Once a result is ready, the lab sends the report to the ordering physician, and the results are given and explained to the patient by the physician or genetic counselor. This is how genetic testing should be done. However, there are some places that do genetic testing direct to consumer, where they skip the second to last step and the results are reported directly to the patient. This can be very dangerous because genetic testing results can often be difficult to interpret, and the untrained patient might not be able to properly understand the results. Here's what I mean when I say that the results need to be interpreted by an expert professional. These results could be very complex, and each result can mean a different thing depending on the test that was ordered. Let's start with positive results. A positive result can mean one of many things, depending on the complexity of the disease. For example, a positive result from a diagnostic test means that the genetic test has identified that the patient has a mutation that caused them to have the disease. So a doctor might say to a patient, "We did genetic testing, which revealed that your child has cystic fibrosis." Predictive or pre-symptomatic genetic testing is a little different. For those kinds of diseases, the doctor might say, "You have the mutation for Huntington's disease. You will start to show symptoms within the next few years." Predisposition genetic testing results mean that being positive makes you more likely to develop the disease than someone who does not have the genetic mutation. So for example, the doctor might say, "You have a mutation in your BRCA gene. This puts you at increased risk to develop breast cancer." And a positive result from a carrier test tells us that you're not affected, but you have the potential to pass on the mutation to a child. So the doctor might say, "You are a carrier of sickle cell disease." Negative results are even more difficult to interpret. Depending on the situation, your negative result could be reassuring, but it can also be uninformative. For example, let's say a woman who has had breast cancer has BRCA testing and tests negative. This means that she does not have a mutation in her BRCA1 or BRCA2 gene, but it does not mean that she is negative for a mutation in another breast cancer predisposition gene. Maybe she has a mutation in BRCA3 or 4, which are not real genes, but the point is that we cannot rule out a genetic predisposition to breast cancer just because she's negative. Another example is, let's say somebody gets carrier testing for cystic fibrosis. If she comes back negative, that means that she's negative for all of the mutations that the lab tested her for. But there could be other mutations that the lab didn't check for. So just because she's negative, that means she's negative for only those mutations she was tested for. There'll always be a residual risk. Therefore, when somebody comes back negative as a carrier for cystic fibrosis, that means there's a very, very small chance she's a carrier, but it's not zero. And every now and then, we'll do a genetic test that comes back with a result that is neither here nor there, such as when someone is found to have a variant. This variant might be benign, but it might also be harmful. Scientists just don't know which. As a genetic counselor, these are the hardest results to have to give my patients because there's just no clarity. When I tell people that I'm a genetic counselor, I usually get a blank stare. Here's what I do. Genetic counselors have a master's degree in genetic counseling. There are currently only 30 accredited programs in the US and Canada. Genetic counselors identify the risk for their patients and/or their relatives to have genetic diseases. When a particular disease is suspected, the counselor will educate the patient about the symptoms, management, inheritance, available testing, and prevention of the disease, if that's an option. Genetic counselors help their patients through a decision-making process and are trained to be a listening ear to the concerns of the patient. When you go to see a genetic counselor, she will ask you questions about your family's health history and will draw it all out in a specialized family tree called a pedigree. Being aware of your family's health history is very important because often diseases that come up that you might not realize have genetic basis. Use opportunities like family barbecues and holiday meals to keep yourself up to date about what's going on in your family's health. I've uploaded a helpful guide to drawing your own pedigree as a supplement to this lecture. It's called Know Your Genes, and I encourage you to take a look and try it for yourself. Individuals in different stages of life might be referred to a genetic counselor. Let's go through all the reasons someone might come to see a genetic counselor. These are some of the reasons a woman or couple may be seen before getting pregnant. Most preconception genetic testing consists of a blood test to determine if the patient is a carrier of a genetic abnormality. Most of my patients are already pregnant. Some reasons a pregnant woman might come to see a genetic counselor are: if the woman is over 35, her risk to have a baby with a genetic disease is increased. If she had a finding on her ultrasound that might suggest a genetic disease. If a woman has an abnormal prenatal screening test for Down syndrome and other chromosomal abnormalities. If there is a known genetic mutation in the family and the parents want to test the fetus to see if it's affected. If a woman has been exposed to something that might have been harmful to the fetus, such as a medication or tobacco or alcohol. Or if a woman has already had a child with a birth defect or genetic disease and wants to see her risk for this to happen again in the current pregnancy. There are several kinds of genetic tests that are available during a pregnancy. Each situation and each patient is different, and therefore some or all of these tests might be ordered during a pregnancy. Often the mother or both parents have blood tests to see if they are carriers of common genetic diseases such as cystic fibrosis and spinal muscular atrophy. Some moms may decide to have a blood test, sometimes accompanied by ultrasound, to determine the risk for the fetus to have Down syndrome and other chromosomal abnormalities. If a woman wants a definitive answer as to whether her fetus is affected with a specific genetic disease, she may have a more invasive test. If done in the first trimester, the procedure done is called a chorionic villus sampling, where the doctor gets fetal cells by taking a small sample of the placenta. If the invasive testing is done in the second trimester, the procedure is called amniocentesis, where the doctor gets fetal cells by extracting some of the amniotic fluid from around the baby. Both procedures have a small risk of miscarriage. Sometimes a pediatrician might refer a patient to a geneticist if a baby is having difficulty gaining weight, or if the baby's appearance might suggest a genetic syndrome. This is referred to as dysmorphic. Children with developmental delays or multiple medical symptoms of unknown origin might also see a geneticist. Some genetic diseases will be diagnosed with a blood test, and some will be diagnosed with a detailed physical exam by the geneticist. And finally, adults. Adults may go to a genetic counselor if they have a personal or strong family history of cancer or other adult-onset conditions. Other referrals include individuals who exhibit multiple medical symptoms of unknown origin, as they might have an adult-onset genetic disease such as Huntington's. Some adults come if a relative has been diagnosed with genetic diseases that puts them at risk of having it too. Aside from the health issues that arise in genetics, there are several other peripheral issues in ethics, law, and the social aspects of genetic testing. There are many ethical issues that come up in the realm of genetic testing. For example, should we be doing pre-symptomatic testing or testing people who don't have any symptoms of a disease? What if they find out they're positive? Then they have to live their lives in fear of getting a disease. What do they tell their children? Another issue is testing minors. Is it appropriate to test minors for predisposition to genetic diseases, such as hereditary cancers? Does it make a difference if there are preventative measures they can take in childhood? Ethical questions regarding one's obligation to tell family members they have a genetic disease arise all the time. Since we share our genes with our family, is it necessary to warn family members if one knows he or she has a mutation? And suppose that a genetic test reveals that a child's supposed father is not the biological father. Must we tell him? Should we tell the mother that we know? Some people also think we're playing God when we're doing genetic testing before a pregnancy, as we're controlling who our children will be. And should we be taking the decision-making away from the patient and placing it in the hands of the expert professional who is charged with benefiting the patient? This is the model with a doctor-patient relationship. Or should we be giving our patients full autonomy to decide whether or not genetic testing should be performed? There are many more ethical issues in the realm of genetics, and this is just a sample. But for all of these issues, there are valid arguments on both sides. Each person will have a different feeling and reaction to genetic testing, and that's why each person should be doing what they feel is right for them and their families. Some people might find it helpful to talk to a spiritual advisor, an ethicist, or a therapist before deciding to do any genetic testing. The law also has a place in genetics. A hot topic in genetics is who should have access to personal genetic information and how should it be used. In 2008, Congress passed the Genetic Information Non-Discrimination Act, or GINA. This law made it illegal for health insurers to use a genetic test result or family health history as a reason to deny health insurance or to decide on premiums. It also protects us at the workplace, as genetic test results are not allowed to be used by employers to make decisions about hiring, firing, promotion, pay, or privileges. Other legal issues that come up in genetics is if a gene could be patented. If so, that means that the lab who owns the rights to it can be the only lab doing clinical testing. Currently, there is a lawsuit that is challenging patents over the breast cancer genes BRCA1 and BRCA2, which is held at Myriad Genetics and the University of Utah. Legal issues also arise in the realm of using samples or genetic information inappropriately. For example, members of a tiny group of Native Americans who live near the Grand Canyon had given DNA samples to Arizona State University researchers in the 1990s in the hope that they might provide genetic clues to the tribe's devastating rate of diabetes. It turns out that their blood samples have been used to study many other things, including mental illness and theories of the tribe's geographical regions that contradicted their traditional stories. Things that they did not consent for were being studied. The lawsuit ended in a settlement, but the point is that genetic testing must come with proper informed consent. Genetics is a very exciting and always evolving field. I hope that you now have the tools to understand what has been going on and what is still to come in the realm of genetics. Thanks for listening. For more information about our program or for questions, please feel free to contact me.